What do you think? You're on.
Okay, we're going to go ahead and get started. Good afternoon, everybody. My name is Victoria Lancey, and I'm the Education Coordinator here at Michigan Center for Rural Health, and I'll be facilitating today's program. I would like to welcome everybody to today's special topic legal grand round on HIPAA security risk update. It's presented by Michigan Center for Rural Health and ISC, who is a short for Integrated Systems Consultants. Before we begin, just a couple reminders. If you're logged into the webinar portion and have computer speakers and like a telephone system through your computer, you can listen to the audio through them. I'll just ask you to mute your computer speaker so we can't, or your computer phone so we can't hear you. If you are listening to the audio via the audio number provided, handouts are located on our website, and that is www.mcrh.msu.edu. Click on the education link on your left, scroll down, click on legal grand rounds, find today's date, and there you will see the attendance forms, presentation, and an evaluation link. Please complete the evaluation and online. It helps us provide more legal grand rounds and education. If you would like to ask a question, please type it into the chat box, or you can also wait till the end of the program and we can unmute all the lines for the Q&A during the Q&A component. Our speakers today indicate no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program, and I am pleased to introduce Mike Zamira, who is an ISC partner and who has over 25 years of operational experience. He has served as president and CEO of Orchid Orthopedic Solutions. Prior to joining Orchid, he served as chief operating officer in Emergent Biosolutions. He has extensive knowledge and experience in HIPAA security risk analysis and assessments. And then our other presenter is Scott Rakita, sorry, I totally butchered your name. I'm sorry, Scott. He's a certified information systems security professional, and he will also be joining us. With that, I will turn it over to Mike and Scott.
Thanks, Victoria.
Yep.
Hold on a second, folks. We're switching seats. And I will take you through, just to let you know how this is going to flow. So Scott and I'm actually in East Lansing in Victoria's office, and Scott is up in our Traverse City office. So I'm going to take you through the presentation. Just to understand our roles, Scott is much more technically inclined than I am. I am more on the compliance side of life for our practice. So I'm going to take you through the presentation, and at the end, we're going to try to leave some time for questions, and Scott and I are both available for those questions. So just to give you an idea how this is going to go, I will, to start with, walk you through a few of the highlights of the Office for Civil Rights and NIST's latest update that they put on early in September. They do a 2-day session for practices and professionals, trying to give everybody the latest knowledge as to how they are looking at HIPAA. security. Then what I'd like to do is go through a little bit of what I just call a HIPAA update and refresher. We do these all over the state, relatively straightforward. Some of this will be review for you folks. On the other side of it, I do find a lot of people that they understand some aspects of HIPAA, but they don't know why or where or how, and that's what we're trying to walk through to help you be a better professional when it comes to privacy and security. And then we'll walk through some recent Office for Civil Rights activity, what they have, some of the recent resolution agreements they've had with various practices, and that just helps you to understand what things they're keying on today and what you need to be conscious of, and then finish up with the Q&A. So hopefully, I know it's a beautiful day here in East Lansing. I appreciate how you guys not deciding to skip out and go outside and have your lunch and instead listen to me. So we'll try to get through this relatively quickly, and again, at the end, we'll leave time for questions. So, without further ado, the NIST OCR conference. So, again, two-day conference. What they try to do is hit on what are the main issues that practices should be aware of, given what they're seeing across the country. And I got 4 bullets there, and I'm going to go in a little bit of depth on each of these. But the one that they hit very hard for an extended period of time, actually multiple presenters talked about the breach notification rule. So one, I'm not going to go through all the particulars on it, but make sure you're familiar and understand what that is all about. I'll give you some details on it, but you need to probably do a little research on that one. Then also the recurring audit issues, things that they're seeing that, frankly, you need to be on top of, because if you are dealing with an OCR audit or there's just a complaint that you have to address, they're going to ping you on some of these to find out where you are. Then the other thing that they hit, and I thought was very productive, they talked on learning from other industries. Other industries have dealt with security and privacy issues in other ways, and Health and Human Services is trying to learn from those, and so we'll touch on a couple topics there. And then this last one, which especially for hospitals, the medical device side, just want to push you on a couple things to give some thought to as you are working with the GEs and the Siemens of the world and buying equipment, things that I think you could do to better serve your hospital or your practice. So with that, the breach notification rule. This is very basic. What is a breach? You can read it there. What we've gotten into is some people who've gotten in some trouble because they didn't report a breach. They looked at it and they said, I don't think anybody got that information. I think we just lost it. I think it's gone, it's destroyed, those sorts of things. When you get yourself in that position and later it comes out that maybe that laptop or that thumb drive actually did end up in somebody's hands, whether it's the media that publicizes it, whether it's someone who finds it and then goes directly to our government to complain, you need to be on top of this. So, and they hit probably 42 different times that almost your get out of jail free card is having your data encrypted. If I lost that laptop and I know that information is encrypted, I'm going to be in much better shape. So they pounded on that fact. So here's what you need to go through if, let's say, you do have a laptop that disappears from somebody's car. You need to think about whether is that information likely going to end up in somebody's hands where they could potentially use that information in some way, and you've lost control of it. So you go through these different questions here to make a decision as to whether you've got a breach notification requirement. And again, on all of this, the easiest way for me to get to you don't have to report this is if your data was encrypted. If it's encrypted, I'm comfortable. Yeah, they've got a laptop there, but it's really a glorified paperweight. They can't do anything with that data. So I encourage you to look for different methods to encrypt. The other piece to bring out related to this is if you're unsure, talk to a privacy professional, a security professional. A lot of times start with your attorney, talk through what happened, what the situation is, they can provide a lot of guidance in this, and many of the attorneys today are up to speed on what the issues are here and can help guide you on it. So if you're unsure, go that route. You don't want to be caught in the situation where later it comes out that there was a breach, you knew of it, but you didn't think it was a breach, so you didn't report it. Now you start walking down a path of potential civil and even criminal potential issues. So be careful on that front. So then getting into the breach statistics. So a couple facts on here, but what I want to do is go to the next page, which is really giving you a nice chart that shows what the breaches that have been reported because they were 500 plus are basically theft is the #1 thing. And theft / loss, if you look at that, we're almost at 60% of the breaches are because someone was in a Starbucks and they left their iPad sitting on the counter, or they're in an airport and they end up losing their laptop. So you got to keep your staff trained and understanding that this is very, very important, that they take care of any of your technology that has any EPHI on it. And I guess we had a little issue with that bottom item there where it says category name. That's actually supposed to say unauthorized access or disclosure. And so that's another big category. And they went round in circles on this, the folks who were presenting. What this really came down to was an employee or someone who has access to your data improperly disclosing that to someone else. So it's not theft, it's almost mistake, if you will. And that is another one. Again, you need to train your folks so that they understand what they can and can't do with that data and how to better control it. And then we step into by location. So what sort of things are happening? And again, if I look at this chart, the two items, one at about 4 o'clock and the other at about 9 o'clock, you're looking at the portable devices at 10% and laptops at 20%. So 30% of this is because people aren't taking care of their devices. And all of the practices and hospitals that we work with are really struggling with this today because more professionals, more doctors, nurses are coming to work with a smartphone or with an iPad or with a laptop, and they're doing work on it because it's easier for them. So we need to figure out how we control that, and you're going to get sick of hearing this word, but encryption. That is your best way to go with all of this data to ensure that if someone does make a mistake, if someone does screw up with the information and they lose it, you're not going to end up in a situation where you've got to call OCR and explain that you've got a potential breach and start down that path. It is not an easy path to go down. So the other things on here that are interesting that has become a bigger issue is the paper records piece, and we'll hit on a couple of the items there with the paper records, but what it really means is most often you didn't dispose of your paper records properly, and that has come up repeatedly over the last 2 years, that people are really looking at it and not as worried about the paper record aspect of things because, hey, everything's on the computer now, so we can get rid of all this. Well, get rid of it the right way. Shredding with shredding service, those sorts of things are pretty important to make this work out. So, and then there's just some other data there in terms of where other issues have come up related to the breaches. So next, recurring audit issues, and I encourage you to, if anything, keep this slide, look at it with your staff. If you're a privacy or security officer in a hospital, talk about this with your staff, because here's where, if you do have some sort of a complaint where OCR is contacting you, they will most likely ask you a few of these questions. So first off, business associate agreements. They might ask for, let me have your policy or your procedure as to how you deal with business associate agreements. So how do you decide who makes the decision? How are you using business associate agreements? They might even ask for send 3 so that they can see that you're actually using associated. And I'll go a little deeper into those later, but just that's a key one. The risk analysis, almost every one of the resolution agreements that the Office for Civil Rights has entered into, and just so everybody understands this, what normally happens is there's two routes for OCR to take some action. One is I have to call them because I have a breach. So I self-report, then they come and they investigate. And what they will do is look at what are you doing in terms of your policies and procedures? What have you done in the way of a risk analysis? How are you managing the security and privacy in your practice? So that will start them down a path of basically entering into a resolution agreement with you, and that will most likely result in some pretty hefty fines. So that's the one route. The other route is a complaint. So someone comes into your practice, into your hospital. The classic example is they're sitting in the waiting room and they overhear the receptionist talking to a patient, and they talk about, yes, you know, Joe Thompson, we will get that prescription for Viagra out there for you as quick as we can so you can get over there and pick that up. Well, person sitting in the waiting room happens to know Joe Thompson, and they just think it's terrible that you said that. Instead of going and talking to anyone, they decide 1-800-OCR. They're concerned now with their own data. So they're going to start reporting, they're going to complain. That complaint, if it's deemed a credible complaint, then the Office for Civil Rights will contact your practice by email, by phone call, and usually they're going to ask for a few things, and it's right down that same list. I want to see a couple of business associate agreements. I want to see your latest security risk analysis. I want to see a few of your policies and procedures that deal with security and privacy. So that's one of the, when I'm thinking about a practice and making sure that I've got the right things in place to deal with the security and privacy aspects of HIPAA, those are the things that out of the gate I want to make sure that I've got that information nailed down. So, so the other items that came up. So it is, once I have done a risk analysis and I realize that I've got information on portable devices, what have I done about it? So I know that that's a risk. I know it's something I need to deal with. Did I look to encryption? Did I look to ways that I don't allow people to take their laptops home? Or I'm doing something to keep the data off those portable devices. How have I dealt with that? The lack of transmission security, this has been a big one. People using text, people using open email that has PHI on it. So I send an email to someone who wants some information related to test results, or maybe I'm even just communicating with another doctor's office, but our practice uses Gmail. Well, I don't have control over that email if it's using Gmail. I mean, it's going out, and I'm not sure where it's going to go before it's going to get to the end user. And if it's not an encrypted email, I potentially have lost control of that information, and I don't know where it's going to end up. So that's a big one. The patching of software, we've dealt with this at a few hospitals where they don't have central updating of the patch management. So if you think about how patching works, this is, let's say Microsoft, sending out information to everybody who's got Microsoft software, telling them here's where there are issues with our program. You need to update this. Well, if I'm a black hat hacker looking to try to get information that I can sell, I know that those are vulnerabilities. So I'm going to try to, if I'm going to try to headbutt my way into somebody's system electronically, those are some of the areas I'm going to go right out of the gate. So patching software is critical. The improper disposal, I touched on that a minute ago. Again, that gets to, I'm not shredding properly, I'm throwing stuff into dumpsters, I'm dealing with, let's say, a copier that keeps data on its hard drive, and I improperly dispose of that copier. Those issues have all turned up recently. And then lastly on there is the insufficient data backup or contingency plans. And they put that together as an or, but those are really in some ways two different things. And we probably see more people who are decent on the data backup piece, but they don't have great contingency plans for what if I face some sort of an emergency, a power outage, inability to get into the practice, so I've got to do things from outside, can't get the EMR up and running, so I got to go web-based, those sorts of things. Not always the best plans out there in terms of how to deal with some of those aspects. So moving along, so the Office of the National Coordinator, and again, so this is another group within Health and Human Services. There's a lot of them out there that are touching different aspects of HIPAA. What these folks bring to the table is a lot of training. And later in the slide deck, I'll show you where if you don't use their site, which is healthit.gov, you really should. It's got some great information, some great training on it. But they started focusing on and spoke of specific industries that are good at dealing with data isolation and keeping identifiers outside of the database, so that I can, even if I did have someone get into one aspect of my system, they wouldn't be able to really get good information if they didn't have the other aspect, which was the identifiers, and those are kept separately and they're encrypted. So, and then the fraud detection piece, they talked a little bit about the defense industry that does a great job with this, and what it comes down to is baseline. I know what sort of activity I have across my network, and I know what should be going on at different points during the day. And I've got basically some set parameters there where I see a burst of activity, maybe in the evening after primary work hours, or I see it during the day at some point that I need to pinpoint what's going on with my system. Why is there this burst of activity? Is someone in the system that shouldn't be? Is someone taking data out of the system that they shouldn't take? So that operational monitoring is something that will continue to be pushed going forward. And these other items are, again, they just walked through where they're going to, so this is the Office of the National Coordinator saying, we're going to be looking deeper at these industries, we're going to take some of their best practices, and we're coming back to you, the healthcare industry, and we're going to have some thoughts for you on ways that you can improve privacy and security. And lastly, and I said this a little bit of a commercial here, so I used to be in the medical device industry and have worked with many of the medical device manufacturers, the OEMs of medical devices, whether it's the Strykers and Zimmers and Medtronics, or the GE Health or Siemens or Philips. The FDA has made it abundantly clear, and I'm even giving you a spot where you can go to the FDA site and look at what they have said, what the guidance is, and it's directed right at the OEMs. It's saying, Siemens, Philips, GE, if you are developing an imaging system and you sell that to a hospital and it's got potential security issues, you darn well better take care of it. That is your responsibility. It is not, so it's a team effort with the hospital, but in the end, you need to make sure that you are taking the lead and getting them updates to control that piece of equipment when it's on the hospital's network or on the practice's network. So I encourage you, if you're a privacy or security person in your practice and you're not involved with procurement, take this to your procurement people. Make sure they understand that, because that's the spot where you have some control over this. You have the ability to say, okay, we're going to invest $1 million in this imaging system. Well, I want, in that purchase agreement, I want assurances that you are going to deal with these issues. When there are updates, that you are going to bring those updates out, you are going to send us those updates, you are going to help us to ensure that that piece of equipment stays in compliance and doesn't become what really is a vulnerability on our system. So I push on this pretty hard. It's near and dear to me because we have seen situations both on a potential harm to patients and on a potential vulnerability to privacy and security. The former is the bigger concern, is that potentially someone could be harmed because someone could get in and do something with that equipment from the outside. So that's huge risk. That's patient safety. But you also get into risk to my system, and that's where I take that to your purchasing folks, your procurement folks, talk about that, see where this can be incorporated into your agreements as you're looking at buying new pieces of equipment. Because I do know today, GE and Siemens really don't, and Philips, they don't look hard. They kind of say, hey, you know, we'll get to it when we can. We're trying to develop the next imaging system. We're not too concerned about the one you have right now. And if you're concerned about that one, maybe you should buy our new model. Well, hooey, that's not the way this should go. This should go where they help to take care of you. So I encourage you to push on that. Okay, so that's the update piece. Now let me just take you through what we've seen on the HIPAA side, and I want to make sure that people understand some of the basics here. I'm going to do this quickly, but I will tell you, it probably happens once a week, maybe once every other week, where I talk to somebody that's a security or privacy person or someone who's got something to do with the HIPAA control within their organization, and they end up saying something about Obamacare, and if it wasn't for Obamacare, I wouldn't have to deal with all this HIPAA stuff. Well, HIPAA and Obamacare really are, I mean, they're decoupled. This came out in 1996, and the idea was, if we're going to be sharing information electronically, we have got to get the mom pot kettle comfortable that that information is going to be taken care of. I mean, so this is 1996. This was 20 years ago that they were looking at this and saying, boy, people are going to be concerned if their medical information is flying all over the place. So we've got to figure out ways that we can get people comfortable that their information is under control. And that's why, you know, we've had all these different regulations that have come out to add teeth to what the privacy and security rules are all about. So I just hit on that to make sure we understand the history, so we're talking with knowledge versus, you know, some people are just throwing things out that in the end it hurts your credibility when you're trying to get people to do the right thing. So let's talk about the privacy rule just for a second and what it's trying to do. It is really trying to, it's that balance. How do I control the patient's information and make sure that we don't allow that to go to places it shouldn't go, and at the same time we share where we need to share so that that patient gets good care and they get it in an effective, efficient, cost-efficient way. And I'll be the first to say we're nowhere near where we should be in terms of that sharing piece and knocking the cost down of healthcare. There are still a lot of issues between different EMR systems and being able to share between them. I understand that, but we got to keep working towards this to give people the comfort that their information will be controlled, and at the same time to get them comfortable that this will help to bring healthcare costs down. So, and I got to add a cartoon. I'm a HIPAA guy. I am, you know, nobody wants to talk to me at a cocktail party, so you got to add something like this in there. And the reason we throw this in there, again, what I see with a lot of practices is they are basically almost handcuffed into, oh my gosh, what can I say? What can't I say? How do I even talk in the waiting room? Can I say somebody's name? You know, it's almost gone to an extreme on some things because people are very uptight about what they can and can't do and how they can and can't communicate with patients. So it's certainly an issue all of us are dealing with. So then we get into the security rule, and the thing I'd like to hit on here that I will tell you is misunderstood is the availability aspect of this. And that is, I have a responsibility to make sure that patient information is available, that it gets to the right places. So I got to be smart. I got to know when I can share and when I can't share. And that's not just, oh, if I don't know, I'm not going to share. I mean, honestly, that's the first step that most people take. And I will tell you that that's out of the gate, that's okay. But very quickly research whether you can share or not. One of the things that recently came out, and this may sound a little strange, kind of roundabout, but when we had the Ebola issue down at Dallas Presbyterian Hospital, all of that forced some folks within the administration to push very hard on Health and Human Services, in particular the Office for Civil Rights, because there were a couple instances where the hospital was trying to get information on one or two of the patients, and the primary care physician was not sharing because they basically were, the person that they were asking for the information was handcuffed. They said, I don't know if I'm supposed to share this with you. Well, dang it, you have to. In that situation, you're sharing between two practices so that they can provide care for that patient. So that's the piece. Make sure your people understand. And again, today, I think we've all just gone to the hey, if I don't know, I'm not going to talk to anybody. I'm not going to answer the phone. I'm not going to respond to an email. I'm not going to send anything because I don't want to get myself in trouble. Well, you can also get yourself in trouble when you don't share. So make sure your people are trained and they understand how important that is. So then we get into, so what sort of information is covered? I think a lot of you know this. This is just refresher. Make sure we understand. Probably the piece that I like to hit on here, though, is when you talk about identifiers, it doesn't necessarily have to be the items right down the bottom of the page: name, address, birthday, social security number. We've probably all heard some of the stories where some folks in a hospital out in California got themselves in trouble because they posted some things on Facebook regarding, they didn't say a name, they didn't say anything about who was in the hospital, other than it was a major star who was in the hospital, and I want to say it was a colonoscopy that they had or something, some sort of procedure. Well, they let that be known. Well, where they got themselves in trouble is at the same time the news media put out that so-and-so star was in the hospital, but it was just for minor procedures. But we don't know the details, but didn't give anything more than that. But now from the Facebook posting, I can tell, okay, that was such and such, that was maybe Brad Pitt who was in having this done. So you need to be careful. And I would tell you, teach all of your people, posting anything about what goes on in the hospital, in the practice, on Facebook or tweeting something out, be extremely careful on that front. It is just fraught with potential problems. So we get into use and sharing of PHI, and again here, the piece I want to make sure that people understand is they've got what's out there called the minimum necessary rule. And what that says is I should only be sharing what is needed to be shared with, whether it's a specialty practice that is going to be doing a procedure, whether it is with a third-party biller, but I have to be very careful that I'm only sharing what's necessary. And I'll tell you where some people have gotten in trouble with this. There are some EMR systems out there that are shared between hospitals and maybe their affiliates. And so I'll give you an example that if I'm an orthopedic surgeon and I'm going to be doing some form of a knee surgery on a patient, well, I get access to their records. Right now, most of the EMR systems don't have a good way to mask some of the information. There may be something in there about a cosmetic surgery that was done 15 years ago. And there's a couple of places where hospitals have gotten in trouble because that patient found out that the orthopedic surgeon saw that information. And they're saying that wasn't minimum necessary. They did not need to know that I had that done so that they could do a knee surgery. Now, there's arguments back and forth as to whether that orthopedic surgeon needed to know that or not, but it did put them in a very difficult spot to where they're dealing with a lawsuit. So careful on that front in terms of what you share and thinking about why you're sharing it. So, and I know it sounds like I talk out of both sides of my mouth, but it is a tightrope to walk. That's the bottom line to this. You need to be thinking about why you're sharing things, what needs to be shared, and with whom. So this is what I try to stress with the practices we deal with. Make sure you have a basic set of policies and procedures. You could work with your attorney. If you're an affiliate hospital or affiliate practice that works with a hospital, talk with your hospitals. A lot of them have probably more policies and procedures than you need, but they could probably provide you with some core policies and procedures surrounding business associates, surrounding how you train your people, how you deal with different aspects of privacy and security. It doesn't need to be a 3-ring binder that's 5 inches thick. I mean, this can be 10 to 15 basic policies and procedures. So look at doing that and getting that in place, and then don't set it in a corner and let it collect dust. Use it. When you hire somebody, make sure that you're training them and helping them to understand what's important here, as we've already talked about. So I push on this: train staff, especially new hires or where you have somebody change responsibilities. If they're dealing with patients on the phone, or if they're dealing with other practices, you need to make sure that they understand what they can and can't do. The other piece is, and I referenced this a couple of places, healthit.gov is a great resource, and it's free. It's a great way for you to get some information. The other pieces is make sure that this stuff is documented. So you have personnel files, I'm sure, of some sort. When you train somebody, have them sign off. It's a great way to just make sure that you've got that information and you're retaining it. And so I touched on this a little bit ago, the physical security part. So physical security is most likely not going to cause you to have a reportable breach. Where someone ends up seeing something, or they end up being able to see a screen, or they overhear a conversation, what that's going to create is a situation where you may end up getting a call from the Office for Civil Rights because that person decided to complain. And I think all of you need to assess that in terms of where your practice is, what sort of people are coming to your practice. I'm always very concerned about the larger hospitals that's where this is rampant, because people feel like they're anonymous and there's nowhere to go, so I have to call and complain. If you're a critical access hospital and the people that you're seeing are people that, it's a smaller community and there's a sense of community, I don't think your risk is as great on this. So understand that when you're trying to decide how far to go with some of those things. But it comes back to doing a risk assessment, knowing what your risks are, and putting the right things in place to deal with those risks. And so these other things are just, again, good practices on how you deal with some of this. So that takes us to the business associates. What I would stress here is understand who your business associates are. If you're not sure how to do that, I would tell you, sit down with someone that deals with the financial end of your business and look through who all of your vendors are. Who are you paying money to? Someone who's a third-party biller, someone who's shredding your paper, someone who is doing your cleaning, someone who is your IT consultant that may be doing stuff with your network or with your computers. Those are people that potentially have access. You need to get them to sign a business associate agreement. And what it does is it helps them to understand what you're expecting out of them given the fact that they have access to your protected health information. Incredibly important. So on the business associate side, that's what I would tell you to be doing. So security risk assessment. Today, there's a couple different estimates that the Office for Civil Rights puts out, and I think the latest one, they said that the covered entities that are required to do a security risk assessment, they figure they're not even at 50% of them that have gone and done this, and that's problematic. So I tell you this so we do security risk assessments for hospitals, for practices, for insurance companies. Across the board, we do that sort of work. This isn't a commercial for that. You can do this yourself. It's not easy, though. I will tell you, you can go to the healthit.gov. They've got tools there that you can use. At a minimum, go and look at those tools and see if you can go through this yourself. What we've done with a lot of practices is we help them the first year to get that rolling, and then so it might be a bit more expensive year one. Year two, we hand off a chunk of that to the hospital or the practice so that they can do a brunt of the work, and we help to do just some of the basic assessment, maybe scanning the network and a couple of other components of that. So we're open to those arrangements where it can work out more cost effectively for your practice. But if you took the incentive money from CMS for an EMR system, they require you to attest that you are doing a security risk assessment on an annual basis. So if you've attested and you haven't done one, you're opening yourself to them coming, this is CMS now, CMS coming in and actually taking some of that incentive money back, which would be a very difficult situation for your practice, I'm sure. And at this stage, Office for Civil Rights and CMS are now sharing it. Where Office for Civil Rights gets a complaint, they might send that over to CMS and say, are these folks that have gotten the incentive money, and are you interested in talking to them also? So it can create a pretty difficult situation for you if you haven't done this, because it will, I guarantee you, if you do a security risk assessment, it will help you to get your arms around what things should you be doing to control your PHI. So the audit results. So this is just basically to lay out what the Office for Civil Rights can do. And with the HITECH Act, it gave them teeth. And I could spend a lot of time talking about this, but it just give all of us brain damage. So I won't spend a bunch of time telling you how this came about and why they're allowed to do this amount of penalties and where this money goes. But if you want to do some research on it, or you want to talk to me about that, I'll fill you in. It's not a pretty picture. But it is what we have to deal with, and we don't have a lot of control over it other than talking to our congressmen and our senators and let them know that we don't think this is right the way they set this up. But today, that's what we have to work with. So some of the results that have occurred recently. So 2012, this was where the Office for Civil Rights was looking to basically profile a smaller practice. This was a 2-doctor practice of a cardiology center, and they had an online calendar. The online calendar gave people's names and even what procedures they were going to be dealing with. They got hit with a $100,000 fine and also had to do some corrective action. Now, I'll tell you, the fines that they end up throwing out there, they've made it very clear, and you can find the videos on the Office for Civil Rights website. They've made it clear they don't want to put any practice out of business. That would not work well for their overall goals. But what they want to do, they want it to hurt. So they're going to be looking at your practice and trying to decide what can you afford. Again, maybe not the best program in the world, but it's the program they've devised, and we've all got to deal with it. So here was one from 2014, and I mentioned unpatched software. That's what happened here for the Anchorage Community Health Services. And again, it's interesting, they hit some hospitals early on in the audits, and now they've started to branch out. And so this was a mental health services group, and same sort of thing. They hit them with about $150,000 fine. This is a not-for-profit, did not have a lot of money. It certainly put a big crimp into what they were doing and how they were serving patients. But it was because of things that they had not done, taking care of business. There were some complaints that led to this. This was an interesting one. This is a pharmacy in Denver. As it turned out, and they got hit with a $125,000 fine for just they threw away old paper records. And as it turned out, again, somebody being a little snooping into their business, saw that this stuff was in the dumpster, called the local news. And this ended up being on the news in Denver, led to the Office for Civil Rights coming out, and basically they said, you guys, you haven't done a security risk analysis, you don't understand what the value is of this information. They threw a $125,000 fine at them. Before I jump to that slide, so the other thing that I wanted to mention to you that recently happened, this came out in September, was there was a cancer care group out of Indiana, and what they ended up doing was they lost a laptop, and this was one of those where they actually did report the breach and went through the process of how many patient records were on that laptop. They weren't sure, but the population probably was in the neighborhood of 55,000. They ended up with a $750,000 fine. So that just came out September 2nd, so a few weeks ago. So Office for Civil Rights is very active today, and I think we all need to be aware of that. So steps to take, bottom line, in your practice, if you're a security or privacy officer, you need to help build a culture of compliance. And you'll hear me talk, if I'm working with your practice, of a culture of non-compliance. We see that often where everybody looks at this and says, yeah, I need to sign off on that HIPAA document, and I'll just sign, yeah, and I need to do that little test you're going to give me once a year, and me and Joey sit down together and we do it. And we need to get more serious about what this is all about so that we're controlling that information and people understand it. If you take it up a notch, your people will take it up a notch, but you've got to build that into what you're doing on a daily basis. Another cartoon, of course, got to have it there, just to keep people understanding what we're dealing with. Lastly, I give you a couple of sites that you can tap into. I've mentioned them, I've at least mentioned healthit.gov. So the top one, though, is the Office for Civil Rights. If you go to hhs.gov OCR, you'll find under the Privacy tab, that's where you can actually, on the right column, it talks about what's new. And I think the top item still today is this $750,000 settlement with the practice in Indiana. Read some of those. They have all of their resolution agreements on file there. If I'm a security officer or privacy officer, if I'm the one where the buck stops when it comes to those things in my practice, in my hospital, I want to be aware of what sort of things are they hitting on. Even to the point where maybe I print a couple of them out and I bring them to if you're doing a monthly privacy security meeting, or you're doing something quarterly, or you're doing some training, bring those things out so people see them and understand them. It'll help this to really stick a little more. At healthit.gov, the other thing that, especially for smaller practices that don't have a training program, if you go in there, it's a little hokey, it's a little corny, but they have got a nice little training video. It's actually it's a game where you have to answer questions to get yourself through the practice. Again, a little corny, a little hokey, but you know what? Corny and hokey work. It helps your people. So if you have your people where I don't have a training program and I don't have time to devise one, you have them sit down there and go through that. And then you document that on such and such a day, whoever, Matilda went through this training and do the print screen of the final screen and put that in their personnel file. Now you've trained your person, you've given them some exposure to what security and privacy are all about, and it's actually a training that the government built for you. So if you go to the healthit.gov, you can find that training. If you have any issues with that, feel free to reach out to me, and I'm happy to help you to find that. Lastly, there's a guide for privacy and security that the Office for the National Coordinator put out, and it's good information. It's overkill. You don't need all of it, but it's a great place to start if there isn't somebody that you have a relationship with where they can help you get some of the policies and procedures. You can go here and really synthesize some of this down to come up with policies and procedures for your practice. And if you've already got policies and procedures, I still encourage you to go and pull this, download this PDF, take a read through it, and see if you feel like you've got the major aspects of your practice covered. So with that, I do want to thank Victoria for allowing us to speak here today. If you can't tell, I'm pretty passionate about this. This is an important topic. I don't want people to get blindsided dealing with the Office for Civil Rights. So that's my one motivation. But the other side of that is I look at this as you have all been entrusted with patient's information, and the fact that you guys are all dialing in on a beautiful Thursday does say that you're dedicated to understand this better and do a better job of taking care of that information. That's what we all have to be doing. So forget the gun to our head from the government and from auditors. What are we doing to take care of our patient's information, and are we doing everything that we can? So that's what I appreciate our time to share some of that with you. And our final slide, just so you guys understand, so we're based in Traverse City. We do a lot of work actually in the Grand Rapids area also. I actually work out of the Lansing area, and we've got a strong practice over in Saginaw. So if you're looking for some help with any of this, we're happy to do it. But again, my real motivation is helping to expose some of this stuff to you so that you're asking the right questions of your service provider, your attorneys, and your people. So I guess with that, Victoria, we want to open it up for any questions. I don't know what I need to do. So.
Is it okay if I?
Yep.
we're going to go ahead and we are going to open up the lines for questions. It looks like we have some questions available here. I'm sorry. It says we have a note, staff should not be sharing passwords. Single sign-on is best. Copiers and printers can be password controlled. Also, don't leave printers with PHI on the copier.
Yeah. All good advice. Yes.
And to whoever is watching without, if you don't have audio for some reason, I have recorded the presentation and I can send it to you.
So we need to take them off mute?
Yep, I will be taking everybody off from mute here. Okay, so all the lines are unmuted, so just be mindful of that. If you have any questions, go ahead and feel free to ask away, and or you can type them in using the chat feature.
Questions?
Go ahead. Okay, so right now I'm not here. So a question just came across, which is intrusion testing required for annual security audit? And that's a great question. So thanks, Jeff. So today, the Office for Civil Rights, CMS, they both talk about doing a security risk assessment. And what they say is, you need to decide from that security risk assessment what else you need to be doing. So is intrusion testing required? No, nowhere does it say that it's required. You need to, by doing your security risk analysis, make a decision as to whether to go farther with doing some intrusion testing or not. But in the end, they're not going to tell you that you have to do that. They're going to say just do the risk analysis and then make the decision from there whether you need to go farther with, whether it's just basic scanning or whether it's doing some intrusion or penetration testing. So right now, there's nothing out there that says you have to do that.
Do we have any other questions via audio or typing in?
I have a question.
Go ahead.
Okay, we are a fire department in and one thing that we have debated a little bit is sort of the building security. We have a tendency to leave the main door open, which is very inviting, and we'll run out on a call, and the main door will be open, or the bay doors will be open. And there is some level of concern that there may be some documents exposed either on computers or on the workstations, the desks, that anybody could wander in and see. So I'm pretty sure that's a concern. But even if that was remedied by more caution on our part, just the way the office is set up here, it's, in a doctor's office, you have the area where the computers are sort of segregated from the people. Well, here everything is pretty open. So if we are working on a report for patient care, quite literally anyone could walk in and see that. And we have several computers that way, and all of our work surfaces. How significant of an issue is that, and what would you recommend we do about it?
Oh, great question, and probably see this at multiple practices when we're out doing a risk analysis. So it is a big concern, especially today, given that more people are aware of the privacy and security rules and what you are required to do. So I would say the likelihood that someone, you hope that they would come in and say to you or to the manager of your practice, listen, I'm concerned about you. You have my information, and I could walk in here and do anything I want to do at certain times of the day. But they may not come and say that to you. They may just make a phone call and report you. So that's where I get very concerned about those sorts of things. It's not that you're going to have a major breach from that, most likely, but you certainly could get yourself in a position where you get a complaint, so then they start asking questions, and it's, what sort of security risk analysis have you done? How have you decided whether your doors should be locked or not? Who should have keys to those doors? When should they have access and when should they not have? So you start that snowball going down the hill, and it gets pretty rough pretty quick. So I would encourage the physical security piece helps you to basically stem any issues that could come from patients having issues that they could complain about. So I would get my arms around that. That would be at the top of my list to get that taken care of before I deal with some of these other things.
Hey, this is Scott Rokita with ISC. Just in that particular situation too, you really need to start thinking about screen savers with password protection. You're talking about, you walk away from somebody might see a report, it might be something you need to look in that lines, even if you lock the doors. Because again, if somebody can look in the window, then they can see the screen, it becomes an issue. The other concern would be they have privacy screens. There's all kinds of tech that you only can see the screen from one angle, not from other angles. So just try to answer technically. There are some physical things you can do to help minimize the risk, but again, you do have to look at the risk analysis too.
Never thought of that.
Are there any other questions?
Victoria, this is Scott again. One point I want to bring up for everybody out there, and maybe people know this, maybe they don't. The reason why this has gotten to be such a bigger issue is everybody always, you hear about the hacking incidents with Target and Home Depot and Macy's. A simple statistic that is out there that is a credit card number on the black market is $1 to $2. There's different estimates out there, but a medical record on the black market is $10 to $20. So now what's happening is the reason why medical has become a target is these professional hackers and everybody else has figured out that they can get 10 times return on their money by stealing health records. So that's the other thing that's also pushing this situation to the front. In the past, nobody cared about medical records other than, I don't want my neighbor to know what procedure I had. Well, now it's become a money-generating thing for criminal elements.
Do we have any other questions?
Victoria,
Yeah.
what can you do with a medical record number? I can see what you could do with a credit card number, but what can you do with a medical record number?
Yeah, go ahead.
So that is a great question, and the thing that is very surprising about that is so insurance and Medicaid, Medicare fraud. So today, we don't have great controls within CMS, and even some of our insurance companies don't have great controls. And what you run into is, especially, so I'm a newer doctor. I've got a very small practice, and I need to make money. So I go and I buy these records and I start billing against them. Probably 6 months ago, CMS had a major crackdown across the country where they did start comparing when procedures were, when basically they were reported, and you had instances where people were billing the same person getting a procedure on the same day, which, you know, if one of them's happening in Minneapolis, Minnesota, and the other one's happening in Phoenix, Arizona, the flags should start going up. It's taken them that long to figure some of that stuff out, but they're starting to get their arms around it. So hopefully the medical records aren't worth nearly as much here in the next couple of years. But today, they are worth a lot of money. I can buy those relatively cheaply if I'm somebody who has nefarious motives, and I can make a lot of money off those over a 6-8 month period of time. And then basically I stop billing on those. I pick myself up. I move to another spot. They're figuring they can get 6 to 8 months out of a medical record number, and then they've got to pick up and move. So that's the issue today as it stands. Hopefully we can get our arms around that as a government and an insurance practice, and they won't be nearly as valuable. That will help all of us. But that's where it is today.
What I kind of struggle with on this, and maybe you can address this, is when you're talking about PHI, I mean, the medical record number alone does nothing for you. The visit number alone does nothing for you. Where you run into issues, though, is where you coupled them with other things like the patient's name, the date of birth, the social security number, you know, your true identifiers in there. You know, when you're talking about PHI, though, the medical record number alone and the visit number alone doesn't really have a lot of bearing. True?
Absolutely true. Agree with you 100%. The issue that we have, and we talked about it, that the Office of the National Coordinator has hit this pretty hard. Keep your identifiers separate so that you're not able to link up the number within your EMR to those identifiers. I mean, and really all I need is what, so if I'm a hacker that has the nefarious sort of motives, all I need is one of those pieces of data. If I can get a social security number or I can get a birth date, I can start working my way and figuring out who that person is, and now it becomes valuable to me. But your point is right on the money. If I can get those decoupled and they're separated, that is going to basically save the day for you. Great point.
Okay, what also kills me is that so many people request that social security number, and I guard that, you know, with my life almost. I mean, that's a financial number, and I don't see where it has any real bearing to be shared. And, you know, and I guess I really don't even see it being a part of the medical record myself.
Yeah, and there's still a lot of discussion on that. So I'm with you on that front, and I am like you. If anybody asks me for it, I probably got 5 questions after that in terms of why do you need it, and then they explain, why do you need it, and where's it going to go. So I encourage all of you to continue to push on those things, because that's only going to help us if we are keeping that information separate, and if it's not available out there, especially electronically, we're going to have better control over all of this. So great points.
This is Scott Rokita with ISC again, and also to answer a little bit more why a medical record can be worth so much more than the credit card. A credit card number is non-persistent, and what I mean is once the bank figures out that credit card number has been compromised, they turn it off and it can no longer be used. A lot of medical records have your family history, your mother's maiden name, your address, where you lived. A lot of them still have social security number. That's all what I call persistent data. That's not something that changes with a person, your date, your age, your birth, you know, gender. And those are all things people often use for identity theft. Because, you know, that's why you start seeing when medical records have a lot more value. It has the other identifying information that gives people that they are able to do identity theft as well as Medicare and Medicaid fraud.
Point.
Do we have any other last-minute questions or comments?
Hi, I have a quick question, please.
Yeah.
We've had a lot of information about HIPAA regarding appointment reminder calls and leaving a message. Is that considered a HIPAA breach?
Yes, it can be. How about that? It depends.
Yeah, that's kind of what we get. So it's kind of a gray area.
If I'm calling on a home, just a home answering machine that anybody has access to in that home, and you know you take it to the extreme, and I'm leaving a message that says, you know, you can come in for your pregnancy exam, reminder, you know, the reminder that your pregnancy exam is at 2 o'clock tomorrow, and that's for a 19-year-old woman who still lives at home and mom and dad don't know, you've got yourself a major problem. If from that message, all they know is that this is my family practice is reminding me that I have a doctor's appointment, probably okay. What I encourage you to do is all of your patients, when they sign up or at this point as they're coming in, you ask them to basically check the box that they're okay with you leaving a reminder for them about their appointment. And then you've basically covered yourself there. But I stay clear of saying anything more than a reminder that your appointment is tomorrow at 2 o'clock. But the issue that comes in is if this is a obstetrician's office, or this is a cosmetic surgery, something that's more sensitive, and a person can tell from that message that, oh, you're going to that sort of a why? That's where you're going to get yourself in trouble. Does that make sense?
Okay. Yeah, so we basically need to make sure they have signed something agreeing to
Absolutely.
reminder
Yeah.
calls? Okay.
Yeah, I think that's the best way to go. It keeps you out of hot water.
Okay, very good, thank you.
Do we have any other questions or comments?
Yes, my name is Tom, and I work for an EMS service.
Go ahead.
And the question I have, and I think I know the answer, but I want to verify it, is we do case studies on runs that we have had for our emergency services unit, and we don't mention any names. We may give information about the patient when we talk. We just review it. It stays within our department, and everybody has signed off on the HIPAA agreements. Okay to share that information with other people as long as we don't use any patient identifiers or names or anything associated with that.
Yeah, it is, but I warn you to be careful. Where you're talking data, where it's all lumped together to talk about the number of runs that you had or the types that you had, I think you're okay. When you start getting into details where when you're talking to someone, they can maybe figure out where you're saying that we had 9 runs to this area of town, or where they can start identifying who it might be, then if I can figure it out, even though you're not giving me an identifier, but I could maybe figure it out or pinpoint it in a way, that's where you got to be careful. So as long as it stays general, you're going to be fine.
So if we make a statement like, we have a 67-year-old female who had a heart condition, this is how she presented upon her arrival, and that's how we address it, what would you do to take care of this situation?
Yeah, so I guess there's still some facts and circumstances there. If you're the area that you're serving, if I can't easily tell that we're talking about, one of 3 people, then I think you're going to be okay. If I'm in a small community, and when I start talking about this and I go into more detail on it, I have a pretty good idea. I know that so-and-so, that they just had an issue. I didn't know what the issue was, but now you've just filled in those details for me. That's where I think you have to be careful.
Okay, even if we have signed HIPAA statements and everything saying that they will not release any information outside of here.
I guess help me out with who are you doing this within your group in a training environment?
Yes, it would be with other EMS personnel that are responding via ambulance to go to patients' homes. And all we're doing is using it as a case study, just like you could pick out of a book. 58-year-old with potential problems, list out some vitals, and what would you do in a case like that?
Yeah, so sorry, I was thinking you were sharing it beyond that. So where you're sharing, so this is within your practice that you're sharing that information.
Correct.
Yeah, you're okay on that front. That's you're trying to provide better service to the people that you're serving. So you're going to be okay on that front.
Okay, thank you very much.
This is Scott from ISC. The only caveat I'd add to that, be careful with what training materials you have. It's great that you're in your training, but if somebody takes a packet at home that has training material and somebody could figure out who you were talking about that's not one of your employees, that will get you in trouble.
Yeah, if we use any information that's written or documented on paper, we always collect that before they leave. So.
Do we have anything else to add? Questions, comments?
We have a question from the Blue Room.
Okay, go ahead.
I have a home health company, and we have about 70 field staff, and they have care plan access through a cloud portal. and they have to sign in to view that. So my concern is that it's not necessarily encrypted and it's on private cell phones. So how can I mitigate my exposure there?
Scott, you want to touch on that?
Yeah, that can be somewhat of a difficult one. You sign in access. I guess the concern I have and question, and you have to look at the technology, when you sign in, are you encrypted communication on that device to the record? And is anything downloaded to those devices? Now all of a sudden you're taking all these private cell phones, and if something's downloaded, they now become a containing of EPHI records. I know when I worked in the defense industry, that was the main reason why they didn't allow private cell phones. It was all company-issued cell phones. There are new solutions out there that are starting to make locations, but they're actual, like Dropbox is a general one, but there's actually specific hardware out there that when it kind of makes a crypto vault. And when you log on to that site, it is encrypted between the phone and device, and what's on the phone, it's encrypted. But there is definitely a technology thing that you're going to have to start looking at. You can't just let any cell phone log in unless you have some of those other systems in place. And those will vary depending on what's going on. I know some, like EHR records, do encrypted communications, but it kind of depends on what you have. So I'm sorry, I can't answer without more detail about your specific program.
And Scott, I would just chime in that the other piece, I would make sure that with that cloud provider, I would have make sure that there's a business associate agreement with them. That will open a dialogue with them to talk about where the controls are of that data and where is it when it's at rest, and is it being transmitted anywhere to where it's at rest somewhere like on the phones. So you understand those pieces. That's what's going to be critical.
Do we have any other questions or comments?
It's done. It's been done since supposedly 1 o'clock, but they.
Okay, if we don't have any other questions or comments, we're going to go ahead and end it just so everybody can get back to their workday. Thank you for taking the extra time to listen to all the questions and comments. If you have any other further questions, go ahead, feel free to email me and I will pass them along to our presenters, or you can indicate them on your evaluation and I will pass those along to the presenters as well. Thank you for joining us, and everybody have a great day.
Thank you.
Thank you.